want to know antiretroviral therapy, you're going to have to be familiar with the life cycle of the HIV, human immunodeficiency virus. In the first podcast, we went over a little bit about the mechanics of it, but for those just joining us, let me just briefly go over. You have the human immunodeficiency virus. The virion here docks like a starship to the cell, the CD4 plus T lymphocyte right here. It fuses, and then it actually basically the envelope fuses, and the viral RNA is reversed, it transcripts to the viral DNA and becomes integrated in the host DNA, and then using the protease enzyme, it actually becomes new budding virions. And why that's important is because your ARTs are basically stopping a selective part of this production. So your fusion inhibitors, we don't use them very much, but those will stop the fusion. Most of our bread and butter, if you will, for ARTs, our backbones are the nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors that work here. And then the integrase inhibitors stop the integration of the viral DNA into the host DNA. The protease inhibitors stop the budding off of the virions, and the maturation inhibitors are still in development, but those will stop the maturation of the virions. So the thought is, if you stop the replication, you can slow down the production of virions and then stop transmission of this virus to other cells. So you're preserving your T cell count and you're decreasing your viral load, ideally to nothing. So I wanted to share with you, I think, a very helpful way of remembering your antiretroviral therapies, and I want to give full credit to Dr. Michael Varada at the Yale School of Medicine, the old San Rafael's Hospital up there in New Haven, Connecticut, who is an amazing HIV clinician. It's a great team up there at St. Raphael's. And I wanted to share this with you because this is adapted from what he taught us. So you have the nukes and the non-nukes, as we like to say, the nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors. For your nukes, you have tenofovir. This is your new tenofovir, alafenamide, which is more renally renal and bone friendly. Basically, you can give lower amounts of the TAF, as we call it now, which is a lot better for the kidneys and bone. The emtricitabine. Now, just so you know, we have these three-letter combinations. That's an historic legacy. Back in the day of early HIV, drugs would be developed, and we'd be given kind of three initials, starting with the old AZT, and so sometimes we use letters. So right here we have the generic name, we have the three letters, which are kind of unofficial, but you'll see that a lot in the literature and in conferences, and then we'll have the brand name. Just a heads up, please use the generics because it's going to make your life a lot easier, and you're going to be able to understand the therapies a lot better. So TAF and FTC give you Descovy. So tenofovir, emtricitabine give you a brand name called Descovy. Now, this is the older tenofovir, TDF, tenofovir desoproxil-fumarate, the brand name Viriad. This is the original tenofovir. It would cause renal insufficiencies, and it would cause osteoporosis, osteopenia. And this older tenofovir plus the emtricitabine gives you Truvada, which we still is first-line therapy for PrEP, pre-exposure prophylaxis, because it has higher, extracellular concentrations. So in terms of trying to prevent infection through mucosal membranes, the Truvada, the emtricitabine tenofovir is still more effective. There's some evidence to suggest that the TAF is very good in the cells, but not so good in preventing new transmissions because it has less extracellular concentrations. Abacavir, ABC, brand name Zyogen, and lamivudine, 3TC, brand name Epivir, gives you Epsicom. And these are basically lets you know what kind of nucleotide or side that they're active in. This is the older one, but this is the original one, AZT, also called ZDV, zidovudine, retrovir, and that together is combivir. We don't use that much anymore. AZT can cause macrocytosis, so it will cause an increase in your MCV. We're going to get that to a little bit in terms of side effects. Didanosine, the D drugs, zidovudine, Zerit, those are D for danger, causes a lot of liver problems. Zidovudine can cause a lot of fatty liver, so if you see fatty liver lectures, they'll usually tell you not to use didanidine and zidovudine, but the good news, in the United States, we don't, so maybe in developing countries, but we do not use this anymore in the United States, and please don't use these didanosine or zidovudine. It's hard to find anyway. So those are your nukes. Your non-nukes, you have efavirenz, EFV, brand name Sestiva. That combined with Truvada gives you a tripla. Rilpivirine is another non-nuke. Rilpivirine combined with Descovy gives you a DefC. So that is kind of the more of a modern combination. Now, efavirenz can also be combined with Descovy, and that is a brand name to be announced, but that's in development. Rilpivirine plus your Truvada gives you Complaris. You can see that knowing your generics is very helpful because basically the brand names are recombinations of your generics. Etravirine and nevirapine are your other non-nukes. We used to use nevirapine a lot in pregnancy, but that is no longer first line. Integrase inhibitors, remember we're stopping the integration into the host genome, is raltegravir. Raltegravir is twice a day. Dolutegravir is once a day, and it's a very small pill, very, very easy to take, very few side effects. And the other integrase inhibitor, elvitegravir and cobicistat. Cobicistat is a booster. So when you talk about boosters, it's basically a medicine that is not active, at least cobicistat is not active in HIV itself, but it increases the area under the curve for elvitegravir, and that way it can be combined with Descovy, and you get Genvoya. So your TAF, FTC, elvitegravir, cobicistat fixed dose combination, otherwise known as Genvoya, and then the older version, TDF, FTC, elvitegravir, cobicistat is Stribold. For your protease inhibitors, these used to be first line. They're no longer first line because it has a lot of side effects for lipids and triglyceride levels and fat distribution. The first line protease inhibitor is darunavir, brand name Persista, and ritonavir. Now, ritonavir itself is active against HIV. In the early days, it was used as a protease inhibitor by itself, but it was found that when these are combined, this serves as a booster, meaning you don't need as high doses of your protease inhibitor if you boost it with ritonavir, which in its own right is a protease inhibitor. So these two together will have less toxicity than darunavir alone. Darunavir can also be boosted with cobicistat, brand name Proscobix. Atazanavir, brand name is Rayatans, and essentially can be boosted with ritonavir. And then basically then you can go for atazanavir. Atazanavir cobicistat is a combination pill now called Evotaz. Older PIs, fosamprenavir, called Lexiva, plus or minus ritonavir, is twice a day, and leponavir, which is Kaletra, it already has ritonavir combined. We used to use that a lot in pregnancy, and that's a little bit harder to take. It's usually 2 pills twice a day, so it's kind of out of favor. And these are the older PIs that we really don't use anymore, and they're hard to find, and they have higher side effect profiles. The CCR5 antagonist is Maraviroc, called Cellzentry. Fusion inhibitors is Fusion, which is an injectable medication, which we don't use because it's very difficult to tolerate injections. So those are the main medications we're using now for antiretroviral therapies. And I wanted to go over now which ones are once a day and which are the side effects, so it gives you a little bit idea. So tenofovir, TAF, Essentially, that's once a day. Green is going to be once a day. Anthracytidine is once a day. Those are very, very good. The side effects for these, TAF has very minimal side effects. You want to watch renal function and certainly get a urine analysis every year when you use TDF. And also, if you start getting mutations, M1A4V, you're not going to be able to use your emtricitabine. But tenofovir, either TAF or TDF, is very good at suppressing hepatitis B. So for your patients who have a hepatitis B core antibody positive, you want to make sure they're suppressed. Usually tenofovir is going to be your first line for suppression. So sometimes you want to definitely keep that in there if they're core positive. And abacavir, remember you have to have your HLA B5701 because you can get severe problems and metabolic disturbances if if you don't test for it, which we always do. It's standard of care now. And lamivudine, that's actually those can be twice a day, but combined in Epsicom is actually once a day. Lamivudine and zidovudine, those, so zidovudine can cause muscle cramps. It can cause macrocytosis, which is usually benign. You can tell if your patient's taking AZT if their MCV is high, usually greater than 80, and some disturbances or rashes as well, but mostly muscle problems with AZT. Combivir is twice a day. Some patients love it, and that's great if they're controlled on it. Efavirenz causes CNS problems, so vivid dreams. Some people get rashes, and I would just double check in terms of these being taken with or without food, because some of them are with food, some are without food, some you can have both. Just to refresh your memory when you prescribe it. Atripla is usually well tolerated, but again, that efavirenz component. So just FYI, if someone has a rash on Atripla, would attribute that more to efavirenz. I wouldn't throw out the whole drug, because I've seen people who do, not so well in Atripla because of side effects or CNS problems. But remember, Atripla combines that emtricitabine and a tenofovir component, so they could be just fine with the other components, but just have problems with efavirenz. So just be careful when you list adverse reactions that you list it ideally by component if you're able to do that. Rilpivirine, you want to make sure that they have viral loads less than, I believe it's 100,000, and CD4 counts that are not so low. So you have a CD4 count and an HIV viral load. Basically, you have to make sure that those are within the right margin for rilpivirine, and then Odefsey is that combination. Complera, as we talked about, is a once a day. So all these are one pill once a day. So Atripla, Odefsey, Complera. Atropine is twice a day, but nevirapine is usually once a day. Rilpivirine is really a great drug because you can prescribe that without a combination pill, and that's a nice adjunct when you start having mutations. Raltegravir is twice a day. Please remember that your patients take it twice a day. We've seen people with viral loads around 300, 1,300, 1,500, and they're just taking the raltegravir once a day. Some prescribers will give 2 pills of raltegravir at once in the morning. I don't think that's ideal. There's some evidence suggests that could work, but if you're going to do that, you might as well just give them dolutegravir, which is once a day. Remember, if you have resistance for integrase inhibitors for the raltegravir class, you're going to have to give dolutegravir twice a day. And that also is if you're prescribing it, I believe, with rilpivirine, sometimes you have to give it twice a day to overcome that barrier. But dolutegravir is a great medicine, very few side effects. And similar with albitegravir, very few side effects. Now, the covacistat, your renal colleagues will tell you, will show a transient increase in creatinine. That's considered artificial. So a 0.1 increase in creatinine once you've started them on a covacistat booster regimen is normal. Just keep an eye on it. I do not like to use hydrochlorothiazide in our HIV positive folks, even though it's considered first line for blood pressure management. I just feel like it, especially in Florida, it just dehydrates our patients so much. So I've had so many cases where we've had people on tenofovir based regimens and or a covacistat regimen, and we just, once we take them off their hydrochlorothiazide, they do so much better with their renal function. So we try not to give them hydrochlorothiazide when you're giving them tenofovir and covacistat if you can, because they get pre-renal pretty easily. So darunavir and ritonavir is interesting. You can do it once a day or twice a day. We have some patients who are on BID, darunavir, ritonavir. Remember, you have to do both. You have to boost the darunavir in the morning and at night. So that's a common mistake. So if someone's on darunavir, ritonavir, so that's 1 pill of darunavir, 1 pill of ritonavir, that's usually 600 milligrams of darunavir, 100 milligrams of ritonavir. That's in the morning and at night. It's a pill of darunavir, ritonavir in the morning and a pill of darunavir, ritonavir at night, 12 hours apart. Don't make the mistake of just giving them ritonavir once, because it has to boost the darunavir twice. For that reason, I like to give darunavir once a day at 800 milligrams and ritonavir once a day at 800. Even better, you can combine darunavir and cobicistat to Prescovix, which is an already combined pill, 1 pill once a day, and that works really, really well if the insurance will sponsor it. Same with the atazanavir. Now, you can give unboosted atazanavir. Usually it's a twice a day regimen, but same thing with darunavir. Remember, if you're giving it twice a day, you give ritonavir also twice a day. But I like the combination here, the Evotaz. By the way, I have no disclosures. I'm not paid by any drug companies. I just like easy dosing for my patients. Ifosoprenavir and leponavir is also twice a day. And these are pretty difficult. There's a lot of pill burden here. I hardly use Calitra anymore. And just FYI, for first line for your pregnant ladies, you want to do, you can actually do a Descovy regimen or a Truvada regimen, plus an integrase inhibitor is helpful. I don't like to use cobicistat or PIs in pregnancy. But there's actually a prenatal hotline in California, and they like to use the Truvada dolutegravir. They have some success with Triumeq, but I would try to do a Truvada and or Descovy plus a dolutegravir. We've had good luck with that. You can also use raltegravir. Raltegravir is even more studied in pregnancy, dolutegravir less so. So you can do kind of like your post-exposure prophylaxis. You can do that regimen. Okay, so just a quick overview of your new generations of TAF-based ART, and the science is moving very quickly. So essentially your old cousin, if you will, TDF, tenofovir diproxylfumarate, and new tenofovir alafenamide. So the Stribold is the older one, the TDF-FTC alvategravir cobicistat. It becomes Genvoya, which is just TAF. You see how everything else is the same? So tenofovir, emtricitabine, alvategravir, cobicistat. So these are really the same, except that substitution of tenofovir from TDF to TAF. And same with Complera. So this is the older one with TDF, and this is the newer one, Odefsey, with the TAF. So we're just substituting the newer tenofovir into this pill, and that's why knowing your generics are so important, because you can understand the pharmacokinetics of it. Same with Truvada, right? So you have Truvada is tenofovir emtricitabine, TDF. Descovy is TAF, FTC, TAF. So Atripla, same thing. TDF, FTC, efavirenz, fixed dose combination, and the name is pending, but it's TAF, FTC, efavirenz. So you can see you want to move, if you can, if you're starting your patients on medicines for test and treat, you want to kind of move towards these TAF regimens. And you can also change your folks over. So if you have folks who are getting up in age and you need to work on their bone density and their renal function, then you can ask them, consider changing to TAF regimens. All right, so some cases, just in terms of opportunistic infections. You have a 36-year-old gentleman in Central Europe, and this is actually from a report by Markowitz et al., coming with a 3-month history of red vascular crusted lesions and a left zygomatic arch tumor. CD4 count is 47 cells with HIV viral load of 2.62 million copies. So you have a gentleman who comes with red vascular crusted lesions and tumors. What could this be? If it's infectious, it can be a couple of things. And here's a picture for those listening in. He has red lesions that are very vascular and kind of scab-like looking, and looks like kind of like bites. And the CT scan is showing kind of tumors and growths, if you will, on the chest wall and the zygomatic arch. And this is actually Bartonella quintana. They're rust-colored papules, and there's a term, pyogenic granulomata, which is a differential, and then Kaposi's was suspected, but a biopsy was taken, and they found telangiectatic vessels in the upper dermis with neutrophils and lymphocytes compatible with bacillary angiotomas and pyodermic granulomata, and kind of a buzzword, Warfarin starry stain showed clusters of microorganisms. So this person was essentially bitten by lice, so body louse. It's also called trench fever. So Bartonella quintana, trench fever, quintana meaning 5, meaning fever every 5 days classically. It's a small gram-negative rod, and we see that sometimes in HIV/AIDS. I have to say I have not, thankfully, seen cases of this in the United States, but it is in literature, and you should be aware of it. And we treat doxy and gentamicin. Bartonella henselae is, so just so you know, the quintana is more of the louse vector. There's also a henselae Bartonella species, which is more from cats, and we see this more in the United States, called cat scratch disease with fever and skin lesions. Bacillary peliosis, which is basically a term for the liver having lesions and stigmata of this infection. Usually the CD4 count is less than 100. You can see it in bone, mucosal areas, CNS endocarditis. You can give erythromycin, so it's easily treatable. So as long as it can be diagnosed, and this is a classic lesion for those listening in, it looks like a starburst lesion in the retina. This is classic. It doesn't always present like this. Case number 2, 32-year-old male, previously healthy, presents with a vascular fleshy lesions over the past 2 months, non-pruritic and non-painful. And this is from the VA caseload. And this is the same manifestations. So it can be dark, kind of macule. It can be raised, kind of papule, and it can be either a few lesions or multiple lesions. And it can also show up in the lungs and the internal organs. And it can be mild or severe depending on the degree of immunosuppression. So you can see it can be a little bit of red dots on the arms, or it can be really, really severe in terms of purple violaceous lesions. And it's Kaposi's sarcoma, which is mediated by humans herpesvirus 8. Usually you see it on the skin or mucosa. Sometimes you see it liver, spleen, bone marrow. Unusual to see in the eye, in the ear, in the brain, and the spinal cord, but anything is possible. And there's also a term called Castleman syndrome. I believe it's more in the internal organs. Something to consider. Case number 3, 38-year-old gentleman from Seattle with raised papules and fatigue over the past 2 months. And it looks kind of like very well demarcated lesions, really non-vascular, but almost acneiform. And a couple of things it can be. This is from Dr. Paul Volberding from the image library on the VA site. It could be, think about it, it could be Musculum contagiosum, could be Penicillium marfani, could be Cryptococcus gattii, could be Histoplasm capsulatum. And what this one was, it was actually disseminated Cryptococcus, so Cryptococcosis, and it could also be helpful, and you can do that. Find out that by biopsy, sometimes serology, and it can happen in the pediatric population as well. And Cryptococcus neoformans or Cryptococcus gattii can also present as meningitis or pneumonia, not necessarily skin lesions. Case number 4, 42-year-old gentleman from Arizona who's a photographer presents with raised lesions with bilateral erythematous shin and joint pains. He came from a trip to Brazil on assignment, and the differentials could be T-cell lymphoma, adult Still's disease, coccidioides or leishmaniasis. And this is actually a Coccidioides immitis called valley fever or desert fever. It's from dust. We see this in people who are outside a lot, either construction or outside professions. And usually we do recommend prophylaxing with fluconazole in solid organ transplant or HIV when they have an IgG positive, and that is a recommendation to check your patients when they're living in endemic regions. And these are pictures of the yeast, encapsulated yeast form, and then you can see the skin form. So in terms of systemic opportunity infections in HIV, classic case, you have a 25-year-old gentleman with difficulty climbing stairs, collapsing after jogging one day across the Golden Gate Bridge, and x-ray looks like this, and this is classic. This is how really the people started finding out about HIV was Pneumocystis, pneumonia, and you can see these lung findings are kind of speculated lesions, and this is Pneumocystis jeroveci, and they're described as crushed ping pong ball lesions. There's alternative, so just so you understand, it's kind of hard to find this beautiful picture in your patient population. You're going to have to work for usually a PCR on bronchoalveolar lavage is really how you would diagnose this, and also empirically if the CD4 counts are low and the x-ray or CT scan gives you cause for this, or if they're hypoxic. Sometimes it's a diagnosis of presentation, but ideally BAL will help you to get this diagnosis. And you do want to prophylax your patients if their CD4 count is less than 200, the percentage is less than 14%, or if they have acute lymphocytic leukemia, or if they're on prolonged steroids, usually more than 14 days. Bactrim prophylaxis preferred. You can either do single strength or double strength daily. At our clinic, we do double strength daily, but technically, if they don't have a toxo history, you could probably do single strength daily. And you can also, they have a allergy to Bactrim, you can do atovaquone. Dapsone is alternative if they have other types of allergies to Bactrim, but remember they also need to have that G6PD activity. Inhaled pentamidine is not used as much anymore because it doesn't cover the whole lung field, but it is a possibility. Case number 6, you have a 34-year-old lady with HIV, CD4 count of 46, with severe shortness of breath and hypoxia findings. And eye exam that looks kind of like described here, maybe flames, if you will, kind of cotton wool spots and flames. Something you need to know for your ID boards, generally speaking, is eye lesions. So it could be CMV, Toxoplasmosis, VZV, HCV. And this was actually toxo, and we see this in immunocompromised individuals. You can see this as pneumonitis. It's rare, but it has been described in literature, very similar to PCJ pneumonia. Toxo we see mostly in our patient population here in Florida as CNS Toxoplasmosis. So unfortunately our patients present with seizure, mental status changes, cranial nerve disturbances, and they're admitted to the hospital, and a CT scan or MRI shows lesions and found to be Toxoplasma gondii and HIV positive status. So that's unfortunately usually sometimes how patients present is with CNS toxo, and I have to say the sequela is very, very severe. People can have lifelong paralysis, lifelong cognitive problems, and that makes obviously life not only very difficult, but also difficult to try to get their viral load suppressed and try to get them back to good health. So by the time HIV progresses to CNS toxo, it's very, very difficult to get that person back into good functioning status. So that's why certainly prevention, but also early diagnosis is so important in control. These are also other types, retinochoroides, and then we use Bactrim for prophylaxis, and now we use that for types of treatment as well, now that our paramethazine is at a premium. This is a picture of CNS toxo. Sometimes it can be classic on MRI or CT. It's kind of a ring-enhancing lesion. Biopsy, depending on your center, can be helpful, but sometimes we just try to treat empirically, see if it gets better, and go from there. Ideally, biopsy is great, but if you're worried about space-occupying lesions, I would consult with your neurosurgeon and see what makes sense. So in conclusion, we have Pneumocystis jeroveci, as Dr. Paulsack says, or Toxoplasma gondii MAC we see a lot here in Florida, and Mycobacterium avium complex, and Coccidioides immitis. A word with Pneumocystis, again, you really want to keep track of your patients with CD4 count less than 200 or less than 14. Remember, it has to be above those levels for 3 months, okay? So if someone just goes above 200, you still want to watch them and make sure they stay sustained above 200 for 3 months before you stop that prophylaxis. Or if someone presents with oropharyngeal candidiasis, regardless of CD4 count, you need a prophylaxant because that means their T cells are not functional. So classic example, someone presents with a CD4 count of 300, you still want to prophylax them if they have thrush candidiasis. So toxo, basically you want to prophylax if their CD4 count is less than 100 and their IgG is positive. If they're negative, you don't need to worry about this as much, and you don't need to repeat this. Really, you check it once at their primary diagnosis, and if they go above 100, you don't really worry about that again. MAC is interesting. MAC is incredibly difficult to treat. It's usually less than 50 CD4 count is what we see. And this presents in all types of manifestations. You'll see this as pneumonia. You see this as abdominal pain. You can have it spread in the blood. So remember, you can get MAC in your blood. You want to send off cultures for AFB. You want to make sure that you give them azithromycin every week, and you want to make sure that you keep that up until they are above 100 for 3 months. And then coccidioides, we talked about earlier. And remember the concept of primary and secondary prophylaxis. So primary prophylaxis is when you're preventing primary infection, right? So usually you want to basically start this, and I apologize, this would actually be above 100. Sorry, this is correct. I'm sorry, that you want to start prophy when you're less than 200 for PCP, less than 100 for toxo, less than 50 for MAC, and then for coccidioides, less than 250, and in an endemic area with IgG positive. Now, you stop prophy when they are showing their immune system is working. So for PCP, it's above 200 for 3 months, you stop. Toxo actually above 200 also for 3 months. MAC above 100 for 3 months, and then Coccio above 250 times 3 months. And secondary means if they've had the infection before. So you're basically waiting a bit of a longer period. For PCJ, it's the same, but for Toxo, you want to wait 6 months above 200. And for MAC, really you have to treat them almost for 10 to 12 months. But usually you're doing secondary prophy. Once they're done, you want to watch them for 6 months above 100. Some people don't get above 100, so you have to really watch them carefully or continue them on prophy. And then for coccidioides, you want to make sure they've, for secondary prophy, at least 6 months with greater than 250 cells. And this is all in your HIV guidelines, so don't take my word for it. This is just a refresher, but I would go back to your HIV guidelines because those change, and that is really the authority. And thank you for your attention, and wish you a lot of luck in your patient care.